So we have still some time for tea. Your tea is under preparation. Okay, so we have some time for hearing the thoughts from a perspective of a person who thinks that technology can give much of solutions. Can make things easy, make things accountable in emergency care, and how this is the food for thought which he is going to share with you. And then it will also kindle the idea of using technology at the present era to the last person standing. So now I invite Dr. Deepak Agarwal to share his thoughts before we break for tea about how this can kindle a thought and improve the emergency care at the grassroots level. Though he has a specialized talk, you know, but he is going to tell his viewpoints of emergency care in the meantime.
Good morning to all of you. I would just like to share my anecdotes and what enthused me in really helping and being a part of the emergency care. When I was a general surgery resident around a decade back, what we call emergency department was called the casualty because it was the British way, and the system was geared in such a way that the casualty medical officer would not get up from his seat, especially if any patient with a uh, with a specialized problem such as a head injury or a spinal injury used to come into the casualty. So the only thing that they used to do was that they would say page the neurosurgeon and ask the nurse to put in a drip. So these are the only two things that they would not even get up to see the patient. And that was my training. I used to see that happen every day. And the neurosurgeon or the specialist doctor would come in and he would write on the file that uh, CT to be done and review after CT. So the patient was at the mercy of all this. A lot of time was wasted and the outcome was not very good, obviously. So I realized that unless the specialists themselves took interest at the ground level and acted as a team, because what was happening was there was a complete disconnect between the different departments working in the emergency room, and this was leading to the patient being the main casualty. So we teamed up, I and Dr. Bhoi, and made protocols, started treating the patient, and we made certain basic what I would say policy decision. One was no specialist would be involved in the care till the patient is fully resuscitated, and no call would be sent till that time. Only after the patient is resuscitated would a call be sent, and the call being sent doesn't translate in that we are waiting for the specialist. The treatment of the patient would go on because any doctor who's posted in the emergency department has the mandate to treat the patient fully, irrespective of whatever pathology the patient might have. So this was a very critical, I would say, policy decision, irrespective of the fact whether there was an orthopedic surgeon, a general surgeon, or an emergency physician on the floor. They had to treat the patient as if they knew everything. And there is no excuse for not knowing. Everybody goes MBBS training, which is common across our subcontinent, in which everything is taught, from how to manage a fracture to how to manage a gynecological emergency. So if you are there, I think it's a huge learning experience. And I think if we put in such a simple policy that no, we will not wait for the other person to come, we'll manage the patient, it will make a huge difference. And it made a huge difference in our center. And another thing which I realized was, because ours is the apex hospital in India, and despite that, there are so many things which remain under the surface. One thing is because we do not allow more than one patient on each bed. So there are certain hospitals, because of the huge crowd, they will allow patients, technically 2-3 patients on the same bed, to admit them, because you cannot send them. But our hospital we don't allow. So any patient, if we beds are full, we send the patients away to on our ambulance to any other hospital. So what was happening on the ground was, because the residents in any system, unless you have very strict checks and balances, people on the ground will keep pushing the envelope to test how far they can go and find shortcuts. So when I was a resident, because I learned it from my seniors, I saw that what used to happen was severe head injury or critical patient, they would write the GCS or the score of the patient slightly higher so that they don't have to intubate the patient, and then across the patient or send the patient to some house. So this was, on the face of it, it looks completely, how can it possibly any doctor do that? But when you're working in the emergency and you have such an intense load of patients coming in, everything seems, that it is acceptable. But it is not. So then we found a solution. We, again, the same solution, we said that the specialist doctor will not be involved in the initial care, so that decision is impartial in the resuscitation of the patient. Whatever has to be done within the golden 5 minutes or 10 minutes, without the specialist telling that then we don't have the CT working, don't do anything, send the patient away, or we don't have this facility, don't see the patient. So the first aid is not just simple first aid, full resuscitation of the patient, and then start talking that, look, this is the patient, we have got stuck with it, he's already intubated, you have to think 100 times before you send him away or do something about it. So it was a sea change in our scenario, and very simple steps made sure that people on the ground were not trying to, take advantage of the system. And this is something which I have seen personally is, and I don't know if it is across the subcontinent, but a colonial mindset which is there in India and maybe in other countries around us, is that if a patient or a relative of the patient walks in well dressed, speaks well in English, then even the guard will salute that person and talk to him nicely for no reason. If a patient is not well dressed or he looks poor, then even the lowest person in the hierarchy in the hospital will act as he is the boss. So it is a very, very weird kind of attitude which you see around you in a system, which needs to be addressed at the core, because that is a mindset which has come down. We've been ruled for more than 200 years, so I don't think it will disappear suddenly, but it is disappearing, but it will take a lot of time to change it, so that any person who comes in is accepted with respect and dignity which a citizen of a country should be getting. So this is, I think, these things are not ever spoken out, but this is my personal, I have seen it happen every day in our emergency departments, and it is something which really troubled me, because when I saw this happening, initially I was not able to understand why this was so, but then I realized that this is the way things happen. Even for us, I've been convent educated throughout my life, and always I was taught to speak in English. But now at this stage, after 20 years into practice of medicine, now I have to relearn to speak in vernacular, in Hindi, which is now become my second second tongue. I'm not so good in Hindi, in speaking, in talking to patients and relatives, giving addresses in Hindi, and I feel that somewhere the system has failed us, that we become disconnected with the citizens in such a way, and we propagate that to have a elitist class or a hierarchy in the system. And the end result is the actual people, the common person, suffers because of this false elitist attitude which we inculcate over the time. And it is the patients and relatives finally who bear the brunt, because in any public sector hospital in India, a phone call or from the ministry or a senior person will do wonders in the care. And if there's no phone call, it is just as anybody else. So with these thoughts, we need to look at the emergency care in a very holistic way. It is not just the resources available on the ground, but it is a major attitude change which we need to inculcate among all the stakeholders to actually improve the care. Thank you so much.
Thank you, Dr. Deepak, and yeah, I welcome Dr. Sanjay Rai. So, Dr. Rai, can you just introduce yourself to the group? So we had a round of introduction.
Good morning, everybody. Really, I'm very sorry for being late, and I was stuck in Delhi's traffic. So,
No problem, sir.
I'm Dr. Sanjay. I'm professor in Community Medicine Department, All India Institute of Medical Science in New Delhi. Thank you.
Sir works in he has got a lot of work on primary healthcare, and he is also looking after our Ballavgarh program, Community Health Center, and we are trying to develop emergency care, community emergency care initiative with Dr. Rai. So that is his full introduction. So now, can you just introduce yourself, Dr. Naik? Yeah, please use the mic. You please be seated and use the mic, please. Yeah. So Dr. Naik represents state of Odisha, and especially these are also one of the states where a lot has to be done. And actually, basically, I personally myself I belong to Odisha as well. So thank you, Dr. Naik, for coming and representing state of Odisha. So Dr. Tej, is the time we have to break for a tea? Tea is ready, or is it? Sorry, or 2 more minutes? 2 more minutes. So we can actually break for tea. So this is a time, and this is a time where we have chance for the participating the presenters to load your presentations. So we'll have a 15 minutes break, right? Is that okay? Half an hour break. In the meantime, you please suggest your PowerPoints and all that, and time to interact as well. So please feel free to interact with each other, know each other. That is also key.